Bismillahirrahmanirrahim. Today we will have case quiz number 121. Case data: 10 years old female, so child female, complaining of pain in both the elbow joints followed by pain in the left knee joints and both the ankle joints in a course of 8 days, so a case of polyarthralgia of acute onset only 8 days. This was accompanied by fever for the past 2 days. Examination revealed vital signs were stable. Both the elbow joints were tender and the knee and the ankle joints were swollen and tender, so not only polyarthralgia but polyarthritis. The patient also had multiple subcutaneous nodules over extensor aspects of both her forearms, both her tibial chains, and few on her thighs. Cardiovascular examination showed presence of soft pansystolic murmur of grade 2 intensity over the left sternal edge. Investigations showed CBC showed leukocytosis, CRB was elevated, and elevated anti-streptococcal lysine O titr, ASLO titr. And two-dimensional echo revealed a mild tricuspid regurgitation. Therapeutic follow-up of this patient: the initial diagnosis of acute rheumatic fever was made, and the child was started on penicillin and aspirin. However, the patient continued to have excruciating arthralgia, and hence a rheumatologist opinion was taken. The child was advised a skin biopsy from a nodular lesion which shows small and medium vessel vasculitis. Hence, she was stopped with aspirin therapy, given pulse therapy with methylprednisolone, and continued with penicillin therapy. Her arthralgia subsided within a day of pulse therapy, and the subcutaneous nodules gradually disappeared. On discharge, the child was put on oral steroid therapy and penicillin prophylaxis and advised regular follow-up. So, what is the diagnosis? Take a break and think of the case. The case has positive ASLO titr and polyarthralgia fever of acute onset associated with elevated CRB and leukocytosis and pansystolic murmur and small and middle vessel vasculitis on skin biopsy. So what is the case? The answer is yes, cutaneous polyarthritis nodosa, CPAN, cutaneous polyarthritis nodosa, which is a form of polyarthritis nodosa, medium vessel vasculitis. This is the biopsy of the case. Shows segmental fibrinoid necrosis with inflammatory infiltrates of small artery and leukocytoclastic vasculitis with fragmentation of neutrophils and in and around blood vessels. Discussion of the diagnosis. Cutaneous polyarthritis nodosa is not common in the pediatric population, with approximately 140 cases only reported in the literature until now. Disease is limited to skin, joints, and muscles in the majority, with a minority having nerve involvement. Constitutional symptoms are common. Most children have a chronic and relapsing benign course. The precise etiology of CPAN remains to be unknown. However, an immune-mediated mechanism has been postulated, with several infectious and non-infectious conditions have been associated both to initiation and relapse of the disease. Among them, streptococcal infection has been commonly implicated. Although some evidence of streptococcal infection as an initiating factor for CPAN is present, Caution must be exercised when interpreting elevations in the serological markers of streptococcal infection in the absence of appropriate clinical presentation. As in rheumatic fever, not only ASOT titer is sufficient for the diagnosis of rheumatic fever, which is a common mistake, especially for the non-rheumatology specialist. They make ASOT analysis if it is positive, so the case is rheumatic fever, which is very wrong. Cutaneous and systemic BAN share the same histopathological features of necrotizing arthritis of small and medium-sized vessels. Cosamol and Meyer described the first case of systemic BAN in 1866. Early reports confirmed that CBAN is a separate entity to systemic BAN. We have limited our definition of CBAN, cutaneous polyarthritis nodosa, to disease affecting the skin, muscle, joints, and peripheral nervous system, with corresponding biopsy confirmation. Any evidence of visceral involvement, either clinically, central nervous system, pulmonary, cardiac, gastrointestinal, or renal, radiographically abnormal angiography, for example, or by histology such as visceral biopsy, were classified as systemic BAN, systemic polyarthritis nodosa, and not cutaneous, not polyarthritis nodosa. Nakamura et al. Proposed further restriction of the definition of cutaneous BAN, and that any extracutaneous involvement such as peripheral neuropathy and myalgias must be limited to the same area as a skin lesion. Systemic BAN and cutaneous BAN appear to be fairly distinct entities on clinical continuum. There are only 5 reported cases of CBAN evolving into systemic BAN. So, cutaneous polyarthritis nodosa is not expected to evolve into BAN systemically unless in very few cases. On review of treatment regimen reported in the literature, most children respond to corticosteroid. Penicillin should be considered in children with increased ASO titer. Recent case series report success with low-dose methotrexate, cyclophosphamide, intravenous immunoglobulin, and biological therapies, so all of these may be used as steroid-sparing drugs if needed. Now to take a key message for this case. CBAN, cutaneous polyarthritis nodosa, can be challenging to diagnose and manage. A diagnosis of CBAN should be considered in a child with fever, tender subcutaneous nodule, libido reticularis, and arthralgias or arthritis. Most children respond to corticosteroid and have a benign course, but some children may be corticosteroid dependent or corticosteroid resistant, necessitating other immunosuppressive agents including DMARDs and biological therapy, as I said before. Multicenteric pediatric vasculitis disease registers are necessary to inform development of standard and the standardization of the best clinical practice for childhood CBAN, which is a rare condition. And finally, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 122. Wassalamu alaikum wa rahmatullahi wa barakatuh.